Good morning, everybody. My name is Dr. Jyoti Sharma and working as assistant professor in PGMS Rohtak at the Department of Pharmacology. So the title of my study is Metabolic Derangement with Antiepileptics in Children Suffering from Generalized Tonic-Clonic Epilepsy. So epilepsy is one of the most prevalent non-communicable neurologic conditions with a lifetime incidence of 3%, with more than half of the cases that begin in childhood. And the highest incidence of epilepsy in children, coupled with the need of long-term anti-epileptic treatment, it can lead to the development of metabolic complications at an early age. So the metabolic derangements, they are hence slow in onset, insidious in progression, and manifest very slowly. So these adverse metabolic effects of anti-epileptics, they are usually underestimated and is an area of legitimate concern. So the aim of my study was to estimate the derangement of metabolic parameters among children suffering from generalized tonic-clonic seizures treated with anti-epileptics, either monotherapy or polytherapy. So material and methods, this was a cross-sectional and observational study conducted at Department of Pediatrics and Pharmacology. Approval was taken from the Institutional Ethics Committee. We recruited 50 children with GTCS stabilized on anti-epileptics for at least 3 months. The inclusion criteria were children of the age group of 5 to 18 years of age of either gender who were on stable anti-epileptic drugs for at least 3 months, and the parents who were willing to provide the written informed consent, we included those children. The exclusion criteria were children having other than GTCS seizures, they were excluded from the study, or any other focal pathology or lesions of the brain, or children with already having any metabolic derangements like diabetes or dyslipidemia, or on medications such as steroids which could affect the body weight status of them. So they were excluded, and also children with other comorbid neurodevelopmental conditions and other chronic medical conditions, they were excluded from the study. So this was the overview of the anti-epileptics which were prescribed to them. So in the monotherapy group, among the first generation, the drugs which were prescribed were the valproate, phenytoin, and carbamazepine. In the second generation group, the drugs were given, these were the levetiracetam and oxcarbazepine. In polytherapy, the various combinations were prescribed to the children according to their clinical need. So there were combinations of only first generation drugs like valproate and phenytoin. There were combination of first and second generation drugs, first and third generation, but only one third generation drug, that is clobazam, was prescribed to the children, and first, second and third generation combinations, they were also prescribed. So the derangement in metabolic parameters were considered were the lipid profile, if the high density lipoprotein levels is less than 40 milligram per deciliter, or the triglycerides value more than or equal to 150 milligram per deciliter, the fasting blood glucose, if it is more than or equal to 100 milligrams then per deciliter, then it is considered to be deranged, and the waist circumference for central obesity, if it is more than 90th percentile, and the blood pressure, if it is more than or equal to 130 by 85 millimeters of mercury. So a total of 72 patients attended the epilepsy clinic, and ultimately we came down to the 50 patients depending upon the various inclusion and exclusion criteria. So the demographic and clinical characteristics, the mean age in years was 10.2 and 10 years, and there were more males in the study as compared to the females. The mean duration of treatment was 2.7 years, and it was just a coincidence that we found that the half of the children, they received monotherapy and half received the polytherapy. This is a distribution of anti-epileptics. So in the monotherapy, the most commonly prescribed drug was the valproate, and in the second generation, most commonly prescribed drug was levetiracetam, and in the polytherapy, the most common combination which was given to the children was the combination of first, second, and third generation anti-epileptics. So coming to the derangement in the lipid profile, we have found that the derangement in the lipids was more common with the monotherapy as compared to the polytherapy, and in the monotherapy, the derangement in lipids was more with the second generation, that is levetiracetam, as compared to the first generation. Coming to the derangement in the fasting blood glucose, it was more seen with the monotherapy, again as compared to the polytherapy, but this time the fasting blood glucose was deranged with more with the first generation anti-epileptic, especially with the valproate. Coming to the central obesity, we found 3 children with having central obesity among the 50, and it was just equal in monotherapy and polytherapy. The prevalence of central obesity was seen in 2 patients on mono and 1 patient receiving polytherapy. The central obesity was seen with phenytoin and valproate in mono, that is with the first generation, and combination therapy in the polytherapy. We found only 1 child having altered blood pressure values, that too with a combination of first and third generation, that is the child who was receiving polytherapy with valproate and clobazam. So, the overall prevalence of metabolic derangement, that is the derangement of each parameter, it was around 26%, and the maximum the derangement was seen with the monotherapy as compared to the polytherapy, and in the derangement of lipids was seen more with the monotherapy, specifically with the second generation, and the derangement in fasting blood glucose was seen with the valproate. So metabolic syndrome in children, it is poorly defined. We don't have a common consensus about the metabolic syndrome in children. We have different guidelines like IDF guidelines, NCEP, ATP3 criteria, WHO guidelines. So we don't have the common consensus that what is the proper definition of metabolic syndrome in children. So the long-term therapy with antiepileptics in children, it can lead to metabolic derangements which could make them prone to metabolic syndrome. Clinicians should actively sort for these symptoms whenever antiepileptics are being prescribed to them in order to prevent these complications, and hence the metabolic syndrome need to be defined in children, and more studies in this direction they are required. Thank you. No, sir.
Any reason why patients with monotherapy seem to be having more metabolic derangements and polytherapy? We would have expected the other way around.
Yes, sir, but still now, because right now we cannot conclude anything, because the sample size is right now very small, and still we are recruiting patients. We have the sample size, this limit is 144 according to the incidence and prevalence of the study, so we are still recruiting, and this is just the initial findings which we have found. And the most of, because we have the government hospitals, so mostly the first generation drugs they are prescribed, and that too, that is a valproate. In the current years, 2 to 3 years, the second generation drugs they are being prescribed now. So we are just finding out that what is the exact prevalence of the impact of second generation on these metabolic effects. So because first generation effects we already know, we have previous studies.
So other thing that you have not mentioned here anywhere is a dose. Maybe patients on monotherapy are getting more dose per kg compared to those who are getting the same drugs in polytherapy. So if you had mentioned the dose, that would have showed us a difference.
Yes.
You said it's hard to draw conclusions from what you presented, right?
Sorry, ma'am?
You said it's difficult to draw any conclusions from what you just presented, and you said it's an ongoing study.
Yes, ma'am.
How can you design your study better to answer the question that you started off with?
Sorry, ma'am?
How can you make a change in the study design that will help you answer your first question better?
Ma'am, we can we can have an analytical study with a by comparison, by keeping a control group as well as the different groups who are receiving different
So
treatments.
the other issue is that your definition of metabolic syndrome is a gray zone, because we don't have clear cut in your age group, that is your average age is only 10 years.
Yes, ma'am.
So this is a place where it will make sense to have a comparison group, an age and gender matched group, which will at which time your values will have more meaning than using cutoffs like this.
Thank you.